I want to welcome everybody to the Dental Hour by Dr. P. This has been going on for 1 year. Actually, tomorrow would be truly a 1 year event since we came back from the shutdown last year. And it has been an exciting journey for me to do this and share these meetings with all the colleagues. It has been inspiring, educating, collaborative, and transforming for me and many that have been going through this 1 year journey. The truth of this was the pursuit of excellence in dentistry. And the more we share, the more we learn, the better we can be. And that transformation has been wonderful. And I cannot see myself stop this program because it has been great. Now, for tonight, it is a great pleasure that Dr. Simmons has joined us and to share with us one of his major interests that he has in sleep apnea, airway and dentistry. Truly, he is an amazing colleague of mine. His devotion is beyond me, and I don't know where he gets the energy, the research, learning, and teaching. He calls himself the perpetual student, which he is. He keeps up with everything. His biography is long. He went to University of Pennsylvania, one of my favorite, graduated in 1981. After 5 years of general dental practice, he returned to UCLA, my wonderful school, and did postdoctoral advanced training in complex orofacial pain and dysfunction problems. He studied dental medical school. He's a part-time faculty now at UCLA and teaching and being involved in research at times that he can. His efforts is amazing. He lectures like the way he's doing it for me as well, and many in the community as well as the medical community because of his special interest in snoring, sleep apnea, TMJ, orofacial pain. Truly, I believe this. Many physicians and dentists and specialists, including myself, we refer to him in case of our complex cases. And he is truly a devoted colleague to coordinate for best care for our patient and his patients. Just a quick review of many things he has done. Is a diplomat of American Board of Dental Sleep Medicine, just emphasizes since 2013, diplomat of Board of Orofacial Pain, lectures at UCLA. He's a clinical assistant professor at USC as well, and he clinical supervisor at the orofacial pain at UCLA clinic from 1990 to 93. Assistant clinical professor of pain management center at UCLA. You can see how many different hats he has worn in the past, from 87 to 90. Fellow Academy of General Dentistry, fellow in pain management at UCLA School of Medicine, TMJ preceptorship at UCLA, publications, many that he would make it available. Chairman of Ethics Committee at our San Fernando Dental Society Valley, as well as president of our dental society. I was there. I was involved with him when he was the president. I was the chair of the continuing education. What an amazing job he did. He has been in dental school curriculum committee, board member of American Academy of Dental Sleep Medicine, board member of American Sleep Apnea Association until now. He has an incredible background, and it's my privilege and a pleasure that he said yes to come and talk during this dental hour. And with no further ado, I'm going to have him take over and present to us updates of sleep apnea, airway, and his guidance in what we can do as a clinician to help our patients. Michael, take over, my friend.
Great. Thank you for the kind introduction and all those things. Yeah, the CV is a bit of a nuisance. It's too big now, but I no longer teach at UCLA and at USC. I did stop after 31 years at UCLA, and there were political reasons why I stopped, and I'll share a little bit about that. It's kind of an interesting story. Tonight, I want it to be fun. I've done these Zooms a few times, and it's literally like talking out into space. So if anyone wants to wave at me and make sure that you're connected, that's great. This was the most recent lecture I did in person, and that was to the American Academy of Dental Sleep Medicine, and that was in 2019. And the topic there is somewhat relevant, and I'm going to touch upon some of the stuff today. And it talks about how dentistry can get involved in sleep, why it's really a public health issue, and why it's kind of a brave new world for a lot of dentists, and a little bit scary because it can be intimidating when people try to corral and restrict the things that you can do. So I don't have any conflicts, and I do thank Dr. P. It's wonderful working with him, and we'll move on to the actual lecture, and please raise your hand or stop me at any time, especially if you have a question that'll challenge the stuff that I'm talking about, because I like to be challenged. So the topic really is sleep disorders and dentistry. It's not quite as simple as just snoring. The question is, where are we now? Because this is a journey that started in the 1980s. Where are we going? And I'm going to tell you where I believe we're going. And for those that are not started, how to pick a pathway to get competent. And for those that are already doing this, how do you get more competent? What can you do? So sleep-related breathing disorders are the main topic, but I'll touch upon all sorts of stuff in sleep so you have a more global feel. So I'll give you the big picture. I'll talk to you about some of the exciting new stuff. And the new stuff is not just technology, but it's also political and what's going on in the world of sleep within America and also within the world, and what seems to be the challenges that we face. And of course, your personal growth in this field is important to me. So I've been educating dental students on this for many years. I did maybe 10 years of education at UCLA to dental students. And one of the reasons that I'm no longer there is they didn't want me to teach this to dental students anymore, which I thought was not the right thing. And that the future of dentistry is with the students, and they need to have the best information to be able to do a good job. So what's the target? It's this crossover between these three circles or fields of interest. And in my background, I started off with dentistry, became a specialist in facial pain and unusual sleep disorders, got a master's degree from a medical school in sleep medicine. So I can speak with a little bit of authority. And then I thought, gee, I'm not being very effective. So I decided, okay, I better get a little bit more education. And so I went into public health, and I went to UCLA and I got a degree there. And that gave me some insights and also freed me up from restrictions that I felt I would have if I was a dentist without other degrees. So I have the background in public health, sleep, pain, and dentistry. And so I also practice some dentistry, not if someone refers me a patient, but just to let you know, they will come back to you and I'll just take care of the pain or the sleep issue. So just to give you a sense of this, how big a topic sleep is, and a sense of, oh, you have an hour, why don't you teach people about sleep? It's kind of if I was going to teach you dentistry and you didn't know dentistry. And you could imagine that there's only a few things that you could really get across, major points. And really, the most important thing is to encourage you to learn more and give you the avenues to get better at this particular topic. So in that light, there's some things that I've done as part of my own initiatives to help. And that is I've made a poster, and it's a 24 by 36-inch poster. It's a big poster you can hang in your office. I have several in my office, and that helps open the conversation with patients that come and see you. And the topic, okay, got sleep. And underneath that says dentists do sleep. That's a DDS. That's what DDS really stands for. Dentists do sleep. The other thing is there's this little children's book that I wrote. This was quite a few years ago. And I did it because I was frustrated that I wasn't able to reach adults with the issues of how dangerous drowsy driving was. So after doing that for about 5 years and hammering my head against the wall without much impact, I thought, all right, I'll save the next generation. So I wrote this little children's book. And so those two things are items that I'm happy to give away. And I'll tell you how to get them at the end of the lecture if you hang in there. So when I speak about sleep as an enormous field, this is the Sleep Bible. It's in its 6th edition. It weighs more than 10 pounds. It is a monster of a book. And at that weight, it doesn't have the references. It only has half a page of references for each of the 171 chapters. You'd have to go online to get to the other references. So there's 317 authors. There's 16 dentists that are authors in this book. So dentistry is represented. 11 of those 16 have a PhD. 3 are from the US. Of the 3 in the US, I believe one has a PhD, one has a master's, the other one is me, and I just had a dental degree. That's one of the reasons I went back to school. It's like, geez, I don't have very many degrees to be in this book. So there's one dentist worldwide who is the section or deputy editor, and that's Gilles Levine, who is definitely a pioneer and the iconic dentist in the world in sleep medicine. And he was the dean of the University of Montreal, and he stopped being the dean maybe a year ago. Anyway, this book is really something that keeps you humble, because when you pick up this book and you start reading it and it's very small print, you realize that this is an enormous lifelong learning kind of topic. And these are the 3 icons. These are the 3 main people that wrote this book in its 6th edition. 7th edition will be out in a year or two. And that's me on the side. And you can see the guy in the middle. That's Bill Dement. He was in his 90s and he just died about a year ago. He taught at Stanford for many, many years. One of the most famous courses that everybody loved. And he's literally the father of sleep medicine in the United States. And I've sat down and had chats with him, and even into his 90s, he was just a brilliant guy and so happy to chat and speak with everybody, and just an all-round fantastic human being. Anyway, some of you may have read this journal. A few years ago, I was the lead author, or I guess, what do they call it? The invited editor, guest editor. And it was all about sleep disorder breathing, and the stuff that I wrote about is still mostly true. And I invite you to look it up, and you'll find it if you go to your CDA website. So I'm going to cover a little bit about sleep because I want to get into the newer and exciting stuff more than give you the background, because 1 hour, I have to pick the things that I think are going to have the most impact on you. So just to give you a few simple sort of background things, just in case you don't know anything about sleep. Sleep is something that you have pretty much all every day if you are looking after yourself. And it's a temporary physiologic loss of consciousness. You lose awareness of your surroundings. But more importantly, it can be reversed with appropriate stimuli, meaning if I cry fire, you're going to wake up. If I'm your baby and I cry, you will wake. If you do not wake with the appropriate stimuli, then we are not in normal sleep. And there's 3 states of being, normal states. I'm not talking about drug-induced states. You're either awake or you're asleep. And if you're asleep, you're in 2 different stages. They're very, very different. One is non-REM sleep, and that's rapid eye movement sleep. And the other is rapid eye movement sleep. Rapid eye movement sleep is very interesting. It's different. It's like an altered state of being. You're cold-blooded. You have spinal paralysis, and you basically have disconnection, or I would say you're not having your heart and lungs behave in a stable, normal way. So there's a lot of instability of cardiovascular stuff that goes on during REM sleep. And REM sleep is a state where your brain is as active as if you're awake. And the reason that you have the spinal paralysis is if you lived out your dreams, you would probably hurt yourself or somebody nearby. And there are stories of people that have a REM behavior disorder, REM sleep behavior disorder, who've killed bed partners or run down the street screaming, driven cars, done all sorts of unusual activities. That's why the spinal paralysis is so important. So these two sleep states, non-REM and REM, you can live if you don't have REM sleep, but if you don't have sleep itself, the chances are you will die. We haven't done that in human beings, as you can imagine. That would not be approved by human subjects, but they've done it to rats, and within a couple of weeks, about half of them died, and the other half looked very unkempt, hair falling out. They looked horrible. They basically would die from diseases that were probably intrinsically within their bodies that otherwise would not have affected them. But they would look pretty bad even if they survived. Anyway, sleep is sort of an interesting architectural event every night where you don't just go to sleep, but you kind of go through different phases of sleep. It's almost like a 90-minute cycle for adults, and you go from light sleep to moderate sleep to deep sleep and then dream sleep, and then you maybe wake up a little and then maybe you go back into dream sleep. Typically you'll have 4 to 6 dream sleep periods, and they increase over the night. So in the morning you typically will wake up from a dream, and dream is not very deep sleep, but it is definitely a sleep. And if you were thinking about, is dream sleep as important as deep sleep? The answer is probably not, because if you're sleep deprived, you tend to catch up more on your deep sleep. And you tend to have your deep sleep early on in your sleep cycle. So when we look at the percentages of sleep in different and the different architecture, you can see that probably about 50% sleep is non-REM, non-deep sleep, 25% is a deep sleep, and 25% is REM sleep. So just think of it in those simple terms. So what's unhealthy sleep? So if we think about sleep, you might go, well, how much sleep do I need? And the answer is, it depends on your age and what you're doing. I mean, if you're running marathons, you probably need more sleep. If you are an infant, you're going to need more sleep. And we do have a problem where we have sleep insufficiency. So typically I would say to you, you want to sleep 7 to 8 hours a night. The World Health Organization seems to imply that 8 hours is better. But when they've done studies on large populations, they found 7 to 7.5 hours is usually associated with best survival. And when they look at these studies, they're looking at something called all-cause mortality. That means we don't care why you died, but you died, and we're counting you as somebody that died. So it's a pretty clear descriptor, as opposed to other health issues like I've developed diabetes and things like that. So all-cause mortality is lower with 7 to 7.5 hours of sleep per night, and that's in general and in large populations. So sleep insufficiency doesn't speak to living a long time. In fact, 1/3 of the population routinely doesn't get enough sleep. When you don't get enough sleep, you are foggy, you have poor judgment, you will drive foggy, and you will have drowsy driving. And although drunk driving is very dangerous, you may have a little bit of ability to react. If you are asleep, you have zero ability to react. And that's why there's a lot of these single car crashes with fatalities. Insufficiency of sleep affects medical residents, interns, physicians, so many medical areas, because they just are pushed and pushed. There's industrial tragedies, 3 Mile Island, Chernobyl, Exxon Valdez, it goes on and on and on. So when I talk about sleep insufficiency, there's a lot of issues that go on. It's not just you have poor cognition, poor mood, it's you're more likely to die. So getting enough sleep makes a lot of sense. If we were to look at sleep disorders, again, it affects about a third of the population, and we have a crossover. Some are both insufficient in their sleep and have sleep disorders. So the main seven are now sleep-related breathing disorders, sleep-related movement disorders. That includes sleep bruxism, insomnia, circadian or timing disorders, parasomnias, which are unusual behaviors during sleep. Hypersomnolence are people that are sleepy, very sleepy, even when they get sufficient sleep. And then there's other sleep disorder, means it doesn't fit into that pattern, but it is a disorder. And we typically have a classification index, and this is the standard international classification of sleep disorders. And I have both books, and I've gone through them quite carefully. And there were some interesting changes from the version that you see on the left. That's the second edition, and the version on the right. And that actually changed to the detriment of dentists. And there were reasons why that happened. So you might want to look at this and go, well, what exactly are we talking about with the numbers of people affected by the different sleep disorders? And this pie on the left is sort of the standard old-fashioned pie that breaks it down. And there's four main subtopics or four main categories of bad sleep issues. One is obstructive sleep apnea, not just obstructive, but there's central sleep apnea, obesity, hyperventilation. There's issues with central sleep apnea. So just call that sleep apnea or breathing issues. Narcolepsy, which gets an enormous amount of interest, affects very, very, very few people. So it's not one of the main players, but there's a lot of talk about it. The four main are sleep-related breathing disorders, circadian rhythm disorders, insomnia, and movement disorders. And the movement disorders are typically limb movements, like restless legs during sleep, which is called periodic limb movement disorder. Now, if you look at the pie on the right, it's a more realistic pie. In fact, it's like a pie you'd have at Thanksgiving. And why I like that pie is half the pie, or more than half the pie, relates to sleep related breathing disorders. And you might go, well, how did you change the pie to make more than half all related to breathing? And the answer is sleep related breathing disorders includes people that snore all the way through to people that have horrible sleep apnea. And so it's a very, very big piece of action for people that deal with sleep related breathing issues. And the issue with insomnia, if you think about how many people have insomnia, I want you to break that category down in half, and half of them have insomnia because they have a sleep related breathing disorder. So you can imagine that the pie on the right, the more realistic pie, is actually not overstated by a long shot and probably is understated. Now, why am I focusing in on sleep related breathing disorders? Well, they're the ones that dentists can have the most impact. And they're the ones I'd kind of like you to be engaged in and to make a difference. The difference you make can be just recognizing them and getting them to the right place, or treating them yourself. Sleep related breathing disorders start off very, very mild, and they get very, very severe. So you might be a snorer every time you drink alcohol, and other times you don't snore, or you may just snore when you have a cold. So when you start off normal, you might snore on occasion. And we know people, everybody snores at some time or another. The issue is it significant snoring? So you may change from a normal person that snores on rare occasions to a non-sleepy snorer, and then you may become a sleepy snorer. In other words, that snoring is actually disrupting your sleep. It may have already disrupted your bed partner's sleep, but now it's starting to disrupt your sleep. And then a little further along this trajectory or continuum of how bad it gets is you start to have lapses in breathing and waking up to breathe. And then we term it obstructive sleep apnea. So obstructive sleep apnea has certain criteria that make it fit. And we start off with a certain number of wakings to breathe as normal. So anything under 5 on average per hour of sleep is considered normal. And the process is when you go to sleep and you have a sleep apneic event or a sleep hypopneic event, your airway collapses, your oxygen drops, your brain goes, you need to breathe. How about waking up? So you wake up just enough to breathe, you get muscle activity, you breathe, and that fragments your sleep because you're falling asleep and waking up. And then, of course, it leads to sleepiness. Not in everybody, but the fragmentation of sleep often leads to sleepiness. There is also another continuum, and that is you go from snoring to mild to moderate to severe sleep apnea, and then maybe mixed apnea, and then central apnea. But that is not always the case. So there's a whole language in dealing with sleep, and I'm not going to go through all these things, but the idea is if you want to do this stuff and be able to communicate with people that really know about it, you have to learn the language. It's almost like the language of dentistry. And when I teach the students, I try to let them know that you want to keep this simple. So when you look in the mouth, we're all focused at the front of the mouth and we're looking at the teeth and the tongue. But I want you to look at the back of the mouth. And that's where physicians look. They look in the mouth right behind the teeth. And I want you to look at the back there and see what's back there. And sometimes you have to push the tongue down. Are you able to see my mouse move? No? I can't hear anybody.
Yes.
Thank you for responding. Okay, so I think the goal is to get you to look further back than the back tooth. So I tell the students, look, this is like going to the fridge. There is a lot of stuff in that fridge. And when you open the fridge, you tend to see certain things like right what's in front of you. It's like the milk and the eggs. So for a dentist, it's like the tongue and the teeth. But that's not all that's in the fridge. And sometimes you have to move the milk, move the tongue, and then you might find, wow, there's some artichokes and a pepper back there. Or in the case of the picture on the left, there's a long swinging uvula and some rather large tonsils. So the question is, how did you miss that? And the answer is, you didn't look. So this is always a fun story because this was my son when he was in his early 20s and he came back from college and he basically said, Dad, I know you're just a dentist and you really don't know very much, but would you mind looking at my sore throat? And sure enough, you can see on the right side, there's a rather large ulceration. But if you look more carefully and more dramatically at the airway, you go, what is going on there? How can anyone breathe with kissing tonsils and inflamed uvula? And the answer is, I missed it. So I'm his dad. I teach this stuff and I missed it. So it's very easy to miss this. So how do we test sleep? And the answer is historically with multiple nights in a lab where you're monitored on many different levels. And this particular person is showing a belt, an effort belt, and all sorts of other sensors that go to the head and around the nose, look at airway breathing. What's interesting though is this strain gauge around the chest is now what's being used around the fingers. And that's being used as a way of reading whether somebody is breathing well. And you don't need all this extra information. Now, the more information you've got, the better it is because you're more likely to catch a problem. However, you don't need all this equipment to catch the vast majority of problems. And it becomes much more expensive when you do need all this equipment and somebody being tested in the lab. So this is a bunch of years ago, and people that know about sleep would recognize how long ago this was, is because this is the first watch pad, which is one of those probes that goes on your finger and measures the vascular flow through your finger as one of the ways of measuring whether somebody is having a sympathetic nervous system issue, meaning they can't breathe and their sympathetic system is on overdrive. Now, this was that time was called an out of center sleep test, and the sleep academies wanted to call it that. Previously, it'd been called a home sleep test, a limited channel test, a portable monitor. And right now, the contemporary name is the HSAT, the home sleep apnea test, because it's not really testing sleep, but it is really testing sleep apnea. So this has changed, and this was, I don't know, 10 or 12 years ago when I was sporting these kind of sleep testing devices. And you can see one on my forehead and one on my arm. And those were kind of novel testing devices at that time. Well, today with technology, we're seeing a whole lot more interesting stuff, basically with what your iPhone can do and what these portable testing devices, almost like health testing devices, can do. And unfortunately, they're not very accurate, these testing devices that fit on your wrist and stuff, but they're getting better. And if you think about it, some of the most sophisticated tests now are simply your bed, like your bed full of sensors can pick up things that otherwise you would not be able to pick up with one of these wristbands. And there have been some studies on beds that pick up your body temperature and how much movement you've got and where you're moving from. So in the future, possibly we'll just be going to bed and the bed will tell us about our sleep. But this is some of the many sleep testing devices I have now. I've collected a bunch through the years, and this is just one of these, and I have several of many of them. And I could go through the pros and cons of each of the tests, but your eye might be drawn to the little tiny test right in the center at the bottom, because that is a sleep testing device. And you might go, that's awfully small compared to all these others. So it makes up in being convenient and small and less disruptive, but it loses some other information that may or may not be important. So that newer and better technology is that small, fits on your finger, is taped on, and it can collect 100 hours of information and can be useful for 3 years. And it collects information and it sends it to your phone, and then it's uploaded and somebody can read it and understand what exactly you have as that night worth of sleep and breathing. And this is also newer and better technology, and this uses a slightly different technology, but also measuring vascular changes, and it uses a ring that fits on your finger, and this one's good in that it can be used on children. And they use something that measures cardiovascular or coupling with the cardiovascular system, cardiopulmonary system. So it's actually measuring how well you're breathing by looking at your cardiopulmonary measures. And just with a single ring, they can collect that data. So this stuff is very, very exciting. And it speaks to more than just convenience and ease of use and not disrupting sleep, but also speaks to a whole new technology of what are you measuring during sleep and what have we been measuring and what things are actually useful to measure. And in that particular one, and this is from Sleep Image, you can see on the left, polysomnogram. That's the standard sleep test where the man was standing up with all those monitors on him. And you can see the cardiopulmonary coupling kind of measures. And those things have been matched to be sufficiently accurate. And so this kind of technology is approved by the FDA and it will go on. So we're going to move into smaller and smaller items, and we're going to make it easier and easier to be able to test for people's sleep problems. And this is kind of like one of the readouts that you might get, but we won't go into that detail at this point. So let's talk about it from the terms of, okay, I see that it's kind of exciting. We got some new equipment. I'd like to maybe try that on myself. What do I do? Can I do it? And the answer is, well, if you're me, you're going to do it. If you're you might think twice. And the reason you might think twice is there's a lot of people that don't want you to do it. And so in the past few years, I've been working on how to change the minds of those people that want to do it and those people that don't want you to do sleep testing. So some years ago in 2015, I wrote a resolution with another doc who's pretty famous, whose name's Keith Thornton, and he has developed Thornton adjustable positioners. So he's done a lot of research work and development work on developing mouthpieces for sleep apnea. And he's an incredible guy, very much an inventor. And so the two of us wrote this resolution, and it was brought to the floor of the ADA by Bill Gerlach, who was the Texas one of their representatives, and it passed unanimously. And what it did was it gave the American Dental Association approval to dig into what dentists can do to evaluate and treat sleep-related breathing disorders. And they came back with a resolution in 2017 called Resolution AB 17, and it was the role of dentistry in the treatment of these disorders. And you can look it up. Go to the ADA website or just look up ADA resolution on dentists and sleep apnea, and you'll read it. And there's like 12, 11, maybe 11 different items where they say these are what dentists can do. And one of the things was, yes, dentists can use sleep-related breathing disorder testing, but only to make sure that their mouthpiece is being titrated or being adjusted correctly. So that was a good start for us in dentistry, and I'm happy to be one of the people that pushed that through. But it's not just the American Dental Association. I've been working on the California Dental Association. I've been working on them so hard that they get mad when I stand up with another resolution. But I've been putting resolutions through to try to help dentists do this for about, oh, I'd say 12 years now. And some of them are accepted and some of them are defeated. But I basically get up there and start pushing for dentists to be able to do this. And this is one of them that was successful in 2011. And it was an excellent start. And it allowed dentists to get involved in screening and working with physicians to diagnose sleep apnea. And that didn't mean that they could use a sleep test or not use a sleep test, but they could get involved. So it was sufficiently vague that allowed dentists to get started. But there's been a bunch. You can see all these different resolutions, and my work, and the work of the San Fernando Valley Dental Society that I managed to convince to support me in some of these resolutions. And we've been doing a lot of stuff. The most recent one you can see in 2017 was something that I wrote myself to try to get California Dental Association to get behind SB 328, which is a Senate bill that was to delay the school start times for our children in high school and junior high school. And when I got up there and started to speak, and when you speak on the floor, you got like 250 people there, and a lot of them are arguing with you and don't want to change. But when I started, nobody knew what I was talking about. And at the end of this presentation about sleep and how it affects our adolescents and they don't get enough sleep, about a third of the members of the House of CDA voted to support this. And unfortunately, you need a half of the members to be able to get something supported. So it didn't pass, it failed. But about 2 years later, California actually passed the law to delay school start time. So if you didn't know that, over a few years, we're going to have school start times for junior and high school to be 8:30 or later. And that's a result of all the work that people did. A lot of school boards and, you know, like people that are parents of teenagers and realize how they're wrecks without enough sleep have pushed for that kind of agenda. So we should sort of back up and look at, what is this all about anyway? What's the argument? Why are dentists not just routinely prescribing tests? I mean, in my particular practice, I'm prescribing MRIs and CAT scans and blood tests, med trials. I do that routinely. I give people injections with all sorts of stuff. I write prescriptions for all sorts of medications, sometimes anticonvulsants. It's not unusual for antidepressants and all sorts of other medications. And so why would this be a problem for me to be prescribing a sleep test? And so I'm going to talk about that a little bit, but let's see, what are we actually allowed to do? And you have to get back to the basics when you do this and figure out what is the Dental Practice Act. And so it's the diagnosis or treatment by all these different manners of anything to do with the teeth and the alveolar processes and the gums and the jaws or associated structures. So that means I can diagnose and treat anything in and around the oral cavity. And the question is, well, what does that mean in and around? Does that mean my shoulder, or does that mean my neck, or what does it mean? Well, I can tell you for sure, it does mean the tongue. And interestingly enough, the tongue and the soft palate are both strongly associated with obstructive sleep apnea. So if you look at the law itself, there is just zero doubt that dentists should be able to diagnose and treat these conditions, and they should be able to prescribe the necessary tests to come up with a diagnosis. And so if we back up, and I'd like to back up because it's always important to see where do we come from and where are we going, and then you get a sense of this trajectory for the future by seeing where we started. So back in the 1600s, you could not tell a dentist from a barber. Same chairs. That's probably why dentists use those chairs, because they were so useful. And you can see the first college in dentistry was around 1839 to 1840 in the University of Maryland. Well, in 1844 and 1846, just a few years later, anesthesiology was discovered. It was discovered by two dentists, which is fabulous. They didn't meet with good ends. Horace Wells killed himself, and William Morton was broke by the time he died. And yet they made an enormous difference in being able to help people with anesthesia. And if we look at anesthesia now, it got taken over somewhat by the medical profession. And look at when the American Medical Association was founded. We're pretty close to them, just a few years later. And the American Board of Medical Specialties was founded many years later. And that was founded because people that wanted to start new specialties in medicine couldn't get the AMA to approve it, because the AMA was a political body and they wanted to limit the different specialties. So the American Board of Medical Specialties managed to help people get other specialties like anesthesia, which was a specialty in medicine in 1947. If we look at the specialty of anesthesia in dentistry, it didn't happen until 2019. And if you look at the number of dentist anesthesiologists, 325, about that number, there's about 50,000 anesthesiologist physicians. So being a dentist isn't that bad. We make it to the list of top professions most years. And when I read this most recent one in 2015, it said, your dentist isn't just concerned with your teeth. He or she might also notice signs of undiagnosed diabetes, cancer, heart disease, and other things during an exam. And I thought, that's great, wonderful. Dentists are more than just teeth and gum people. But they didn't mention sleep. And I go, why are you not mentioning sleep? Because this is where I think we're going to go in the future, is the dentist is going to be the intake for most sleep disordered breathing issues. So dentistry's impact on health is kind of interesting. In the past, we hit a home run with fluoride. We were very successful with amalgam. It was an inexpensive way to fix people's teeth. And we've been dealing with health disparities like early childhood caries for many, many years. But what's the future of dentistry? Well, disease detection, catching things early, being in primary care, preventing chronic disease, and cosmetic enhancements. Lips, probably other areas of the mouth are not a question, but when you come to eyes and forehead, that's still a question according to the California Dental Association. But if you wanted to do Botox and fillers in and around the mouth, you now are able to do it. So where does dentistry fit in with health? You can see it's a small part of medicine, which is a smaller part of healthcare and a smaller part of public health. And we see how big public health is with COVID and how they managed it or mismanaged it. So the combination of public health and dentistry, what actually is going on there? Well, first, what is actually health? And you got to understand, health is not just no disease. It's actually a sense of well-being. So just because I don't have any diseases doesn't mean I'm healthy. I could be suicidal with no diseases. And you might say, well, that's mental illness. I go, well, maybe it's undiagnosed mental illness. Maybe it's social isolation. But basically, we need to have a more global feel for health as not just measures of somebody's cardiovascular and pulmonary function. And when we think about health, there's three main pillars of health. And you can look at them there like Roman, or I'm not sure, Greek pillars. I'd have to ask one of my sons who's a PhD in this stuff. He'd know. It's either a set of pillars like that, or it could be a step stool like you can see on the right side. And health is sitting on your behavior as far as your exercise, your nutrition, and your sleep. So public health is kind of like a science of helping people, basically communities, not the individual. So if you said, what's the difference between public health and me as an individual doctor, is as an individual, you might be treating individual patients, but in public health, as an individual, you'd be treating communities. So it's a much bigger picture. And public health's mission is keep people healthy, give them that opportunity. And there's subspecialties. Public health is quite big. So you can have environmental issues, community health issues, epidemiology, biostats, health policy development, getting it through the government. And there's many other subspecialties in public health. But public health also works as the link to bioterrorism, works for the CDC, Human Health Services, offices of the Inspector General, health departments, and also dental boards, which function under the Department of Consumer Affairs. So I want to draw one little separation between a dentist that's a public health specialist and a public health specialist that's a dentist. You might go, well, what's the difference? And the answer is, I'm a dentist and I have a degree in public health, but I'm not a dentist public health specialist, because I didn't go and learn how to manage caries in the underserved or in the early childhood group. I didn't focus on caries. In fact, that's what most of these public health dentists need to do to get their degree, is to actually go out and do oral cancer or oral disease management. Instead, I'm a dentist that's in public health, meaning I start off with public health issues, and then I go, as a dentist, what can I do to help those issues? So when I look at sleep disorders, that wouldn't be something that a dentist that practices public health and does cavity management would be that interested in. But as somebody that's in public health, as a dentist, that would be really interesting to me. And so would managing obesity and addiction and all sorts of other things, bulimia. So those are the things that public health looks at, is the big picture. So let's get back to our target, and we'll talk about sleep now. And sleep, as I said earlier, is something where we see people taking it for granted. And you can see this cartoon that I had drawn up. It's not just Joe that's falling asleep, and there he has his cup of decaf or cup of Joe. And you can see on the photo up on the top right, there's a TV screen with somebody that's having a car crash. So people are crashing, falling asleep. People are crashing in cars. The whole system is essentially crashing because people don't get enough sleep. And the reason is, it seems like you're a hero if you do more in a day. If you don't get sleep, oh, I only slept for 3 hours, I got all this accomplished. So prolonged sleep debt is kind of the norm, and people accept it. And sleep hours have gradually decreased with the invention of the light bulb, and then TV and computers, internet, and now smartphones. And overall sleep is undervalued. And if you think about it, it's like, look at what happens if we want to stay awake. We have awake chocolate bars. We have caffeine gum. We have caffeine in coffee shots. There's no surrender type coffee, meaning I'm not going to surrender to sleep. And then there's death wish coffee, which is probably accurate, because if you don't get enough sleep, that's where you're headed. And what we see is Red Bull commercials. We see Monster drink commercials, and you got to understand that there's a subtle message in this. And it's like, you don't need sleep, you just need to stay awake. And this is one of my public health colleagues. This is a young dentist that actually went through the public health program with me at UCLA. He graduated and he was doing an advanced program at the school and also doing public health. And I go to the Ralph's Market right next to UCLA, and what does he go for? Red Bulls. And he's having Red Bulls all the time. I'm going, you're at public health, what the hell are you drinking that stuff for? And you go, oh, I see. This is like a rack at Ralph's, and you can see how many energy drinks and caffeine in like supercharged drinks there are available. And this is one of the commercials I saw, and you can see the Red Bull commercial, and how to shape up your GPA is basically just don't sleep, keep studying. That doesn't actually work, but that's the messaging. And the other messaging is, okay, you're going to be awake at night, let's have some cookies. And it's like, okay, that's actually the worst thing you could do if you have insomnia, is to reward that kind of behavior. So don't do that. I guess it works in New York, but I don't recommend it. So it's really coming down to, our kids' screen time or sleep time. And if you have a choice, I would guide you to make them have the sleep time. So when you think about how big of a problem is this lack of sleep, it's immense. So this is the Institute of Medicine report. It's a large book. It's really interesting for somebody that loves sleep. And it says, and it doesn't exaggerate, this problem is immense. So let's not minimize this. It's immense according to people that don't really exaggerate. And some of the problems are the available workforce is just not big enough. We need more people doing this stuff. And we also need more interdisciplinary people, more people, not just physicians. There aren't enough of them, not just sleep specialists. There's very few of them. We need dentists and pharmacists and psychologists and teachers. We need everybody engaged if we're going to manage this problem. So really what's happened is we've cut off one of the legs of our tripod type stool, and our health is falling off, and we need to recover it as best we can. And you may go, well, why exactly do we need to sleep? What's the importance of sleep? And this is a nice book written at the consumer level by a PhD in sleep, a researcher from the University of Berkeley, and it came out a couple of years ago, and it's a good read. And then you might go, well, what should the goals be if you were in public health and you were doing big kind of interventions? Well, every 10 years, there's this publication called Healthy People. Started off around 1990. And so there's sort of like 10-year goals for each kind of issue. It might be teenage pregnancy. It might be cancer or people dying in car crashes. So there's a list of different things, and every single thing has a goal, and they hope to achieve that goal within 10 years. Well, they never had anything from sleep until the 2020 Healthy People publication. And that came out, of course, in 2010, because the goal is, what do we reach by 2020? And here's the three goals that they said: increase the proportion of students and adults who get sufficient sleep. That's a good thing. And we're making some inroads in California now to do that. Reduce vehicle crashes due to drowsy driving. We spoke about that briefly. Great, good goal. And then here's the next one: increasing the proportion of people with obstructive sleep apnea symptoms getting evaluated. Now that's a big picture. What can we do to do that, to help that? And it's like, get these people diagnosed. And that's where dentists can start helping in the workforce. And those were the only three that were listed for the 2020 sleep goals. And if you look at all the others, there's thousands of goals and just three for sleep. But at least we were on the table now as something to address. Now, because they were talking about sleep apnea, I want to give you a little bit more detail about sleep apnea, because this is really fascinating with how it's being played with, especially by the American Academy of Sleep Medicine. And I have nothing against the American Academy. I love the members. I just have a problem with the leadership and what they're doing. And here's the reason. And I am a member, been a member for years. Here's Stephen Van Hout, who presents this information at their annual meeting in 2017. And he is the executive director. And this is a big group. The American Academy of Sleep Medicine has between probably 8,000 and 10,000 members. They probably are worth $100 million. They're a big group, and they have a lot of impact. And so he gets up and speaks about how prevalent is sleep apnea in our population. And they've defined it by the number of apneas and a hypopnea index of greater or equal to 5. And so what do they have? As 12% of the adult population has it. That amounts to 23.5 million adults in the United States. Now, if you look at the research, as opposed to what the executive director of the American Academy of Sleep Medicine says, you're going to see that it's actually 25% of the adult population, actually a little bit more, that has sleep apnea. And in some groups, like there's a hypno study where it was much higher than even 25%. Well, that amounts to about 61 million people. So it's like, why would the American Academy of Sleep Medicine only say there were 23 when there's actually more than 60 million people? What's the disparity? Well, it kind of goes back to this report called the Frost and Sullivan report. And this was a report that was paid for by the American Academy of Sleep Medicine. They asked this group to go in there and look at what's going on with sleep in the United States and how big of a problem is it. Well, it turns out it's a big problem, and that if you could address it, you could save a lot of money because treating sleep apnea reduces the costs of the people relative to those same people who don't get treated. It cuts the cost to about 1/3 of the cost of untreated people. So that's a big cost savings if we could identify and treat the people with sleep apnea. So this is kind of their flow chart of sleep apnea. And you can see how they started off with about 245 adults, and they say 12%. And so that means a prevalence, meaning 29 million people with sleep apnea. And here's what's interesting. This is where they say, well, unfortunately, we're not very good at diagnosing these people. Only 80% are getting diagnosed. That's actually not a very good number. And 20% are getting diagnosed. So that's about 6 million people. And of the people that are getting diagnosed, yeah, we're going to teach them get better sleep. That's lifestyle. But really, these are the options that we're giving them. The main options: breathing machine, oral appliances, or surgery. And you can see it's pretty much, well, all breathing machine. And you go, well, that's interesting. Why would they all be going to breathing machine? Why don't they go to the other things? Well, the 12% is important. The other thing that's important is that of the people that do take CPAP or are prescribed it, only about 60% are compliant. In fact, that was in their report. If you ask me, I would say it's about 25%. And I'm saying 25% of the people that would be recommended CPAP don't use it routinely. And you get a lot of drop off along the way. Like some people will look at the machine and won't use it. Some people won't even look at the machine. Some people won't go back to find out about the machine. So when I say 25% compliance, that's after researching this and reading a lot of information. So if you look at that and go, well, can you validate for me this 12% is not accurate? Why would you be questioning the executive director and the Frost and Sullivan report? And the answer is to go back in history and look at this benchmark or landmark study from the New England Journal of Medicine, which spoke about the frequency or prevalence, let's say, of sleep apnea in the population. Up until then, up until 1993, sleep apnea was believed to just occur in obese men. And this study came out and said, well, guess what? Sleep apnea also happens in women. And that was incredibly controversial. And so all of a sudden, people started looking at what actually is going on with the frequency. And at that time, they were saying, well, we're only really going to count people with obstructive sleep apnea that are sleepy. And if you look at the number down on the bottom right, you see OSAS. That means obstructive sleep apnea syndrome. People with a syndrome are the sleepy group. And so you can see about 4% men, 2% women were all that they were really addressing. But if you looked at actually how many people had sleep apnea, it was 24% of the men and 9% of the women. If you divide that, add the two together and divide by 2, you got 33 divided by 2. That means you're already 16+% of the population had sleep apnea back in 1993. And it's only gotten worse because people have gotten heavier with the obesity epidemic and people are getting better at being diagnosed. So we would have a much bigger number than 12, even back in 1993. And if we start looking at the numbers very carefully, like I've done and how I've published on stuff and presented at academy meetings, I go, well, hold on, let's first off start off with a more realistic percentage. That's 25%. And then let's see, well, what does that all break down to? If it's actually 25% of the population, we have to double that number, make it like 61 million. And then we're seeing this same 5 million treated. It sort of changes the numbers. We have a different reality from the American Academy of Sleep Medicine, where their percent of success is 10%. And that's with a 25%. I'm moving it now to a 25% success with CPAP. And I'm looking at the epidemiologist reality, and that's less people are treated effectively. We have a 2% success rate. Now, I would argue this. People can argue it with me, but it's arguable. If they have a 10% success rate at best and 2% is more realistic, you can bet it's closer to the realistic number, which means that current protocols to look after people with gold standard of testing and gold standard of CPAP is 98% failing. You go, well, that's not very good. We need to do something about that. And the answer is, what can we do? So here's the existing sleep-related breathing disorder treatment pie. And you can see if you're going to have surgery or oral appliance, you are not getting very much of the pie. This is who gets the pie, the positive airway pressure approaches. And this is a lot too small to see, but you can look at the actual reference. And basically what it was saying is if somebody has a problem with sleep up here and they go through all the different diagnostic categories and they get down to the problem, they basically have to go through CPAP. CPAP offered. And it's like, yes, it was offered. They accepted it. Great. But you have to go through CPAP in order to get to any one of these other treatments. And it's like, that's not right. People shouldn't be forced to do that. It's almost like forcing you to take one medication before you can try any of the other medications that can work. And PAP versus oral appliance worldwide, and this was back a few years ago, they're kind of similar in that they started around the same year. 1981, Colin Sullivan at the University of Sydney discovered PAP, and he did it in a few patients and published in the Lancet. And in 1982, a couple of physicians, Samuelson and Cartwright, used a tongue retainer or tongue sort of advancement device to treat sleep apnea as an oral appliance. And you can see CPAP is more than $3 billion a year now. That industry is enormous. In dentistry and oral appliances, probably 60 million. I'm sure there's people that get things over the counter and stuff, but basically there's a big difference. So we have tons of devices, more than 100 in CPAP devices and more than 100 oral appliances, although only about 20 are approved by the FDA. So we got to look at this and go, hold on, we got a serious problem. We got people like dentists that can make a big difference. What is going on? Why are dentists being restricted from making impact and helping? And I know a bunch of these people. And so it's not like I don't think these are great people. It's just I don't agree with what they're saying. So this is what they said back in 2007. They said, gee, a portable monitor, like a home sleep apnea test, should only be performed with a comprehensive sleep evaluation. Okay, that makes sense. Don't do a test on somebody without first having some face-to-face exam and figuring out what's going on. But they're saying that these monitors must be supervised by somebody who's board certified in sleep medicine. Well, that's a problem because we have maybe 6,000 sleep medicine doctors in the United States, and we have more than 60 million people with sleep apnea. The math doesn't add up. They just can't do it. That was in 2007. So in 2009, they're still pushing this issue that clinical evaluation should be supervised by a practitioner with board certification. It's like, well, hold on. There's a lot more physicians. Why are you not including physicians? And the answer is, well, they thought that sleep physicians were going to be better at that than regular physicians at sleep medicine. The answer is that's true, but we don't need sleep physicians for everything. It's like saying everybody that has hypertension would need to see a cardiologist. It's like, no, there aren't enough cardiologists. Not everybody has that much of a problem. Only the people that have really serious problems should be seen by the specialist. So this is what the commentary was back in 2009. And if we go a little bit further, we start to see a joint policy statement, which is the American Academy of Sleep Medicine and the American Academy of Dental Sleep Medicine getting together and saying, oh, well, let's figure out something that we can both agree to. And these two people, Leslie Dorton, Sherry Katz, are both very good dentists. I like them a lot, but I disagreed with what they did here. This was not helpful on a population level. And when they were presenting this paper in front of about 600 or 700 people, I stood up at the end and said, I disagree with what you've done. This is wrong. And so it created a lot of, how would you say, turmoil that year, because they were just following along with what the American Academy of Sleep Medicine believed. And that was sleep physicians should diagnose, and only qualified dentists, meaning qualified by the American Academy of Dental Sleep Medicine, should be providing oral appliance therapy for patients. I'm going, hold on, at that time you only have like 300 qualified dentists. What are you doing? How are you going to be able to take care of the hundreds and thousands and millions of people that need care? So 2017, you can see we're getting closer to home and where we are right now. And you can see that this is the message that's going on, that it's important that everything is reviewed by a board certified sleep physician prior to testing. So before I can get my patient sleep tested, they have to see a sleep physician. It's like, no, that's too restrictive. And the follow-up must be through a board certified sleep physician. So they're like controlling who's getting tested. So this is me now, and I'm kind of fighting back, and I'm going, this is wrong. And so I published something in summer, that's spelled wrong, sorry, 2017, about getting educated in dentists. How do you get educated in this stuff? How do you get good at it? How can you actually stand up and do this? So how does a dentist with a deep interest stay on the right path? You have to learn from real experts, study as if it's a passion, and it takes time, exposure, and serious commitment. So it's not as easy as like, I'm just going to do a weekend course. That's not it. You couldn't be a dentist with a weekend course, and you can't be a sleep expert with a weekend course either. So this is how things are progressing. We're now seeing that the primary reason why dentists can't do this, can't diagnose sleep apnea, is that it's a medical condition. It's not limited just to the maxillofacial structures. And it can be comorbid with other medical conditions. And I look at those reasons and I go, that means nothing. Everything is a medical condition. Somebody has an abscess in their mouth or face, that's a medical condition. Somebody has periodontal disease, that's a medical condition. Somebody that has oral cancer, that's a medical condition. We're treating that all the time. Why would we not be able to treat obstructive sleep apnea? Everything's a medical condition. Obstructive sleep apnea is a medical condition. It's a public health problem, and it's got medical issues associated with it. And OSA can be comorbid with other medical conditions. Well, so is periodontal disease. So is obesity. So is everything, smoking. There's so many other issues that are going on that dentists can easily address. Nobody has a problem with, and they all have comorbid issues with that particular condition. So the logic fails to actually have traction. So the joint policy statement that I spoke about basically just doubled down. They basically said, well, we're going to limit diagnosis to sleep physicians. Obviously, regular physicians fought back on that and said, we're diagnosing too. But then they said only dentists with a credential from the American Board of Dental Sleep Medicine, or trying to get that credential, are going to be considered sufficiently educated to be able to provide oral appliance therapy. And remember, there were only a few hundred of them at that time. There's more now, but they doubled down on these myths. Why do I say they're myths? Because it's just not true. And here's one other corollary, is that you would think, okay, only dentists should be applying or providing oral appliance therapy for people with sleep apnea. Well, guess again, otolaryngologists, ENTs actually came out with their revised kind of white paper saying that oral appliances can be provided by the otolaryngologist or the qualified dentist, right? So either an otolaryngologist, there aren't that many of them. There's about maybe 13 or 14,000 in the United States, but only about 7,500 are currently working. And not all of them are interested in sleep medicine. Some do plastic surgery, some do, ear, nose, and throat specific issues. So basically, they're really restricting it, and they're doubling down. They're saying that dentists really should only be the only ones that are doing it. And here's otolaryngologists saying, well, sorry, we're going to do it too. We're totally qualified to do it. And guess what? They probably are. So this is me fighting back again. You don't know this stuff is going on, but I'm writing these articles. And here I am writing an article with a sleep physician who's a leading sleep physician, not only a physician, but a PhD, somebody in Canada that I've lectured with, just a great guy. And he and I wrote this article, and it is a myth based on opinion and territorialism that properly trained dentists cannot diagnose and treat most sleep-related breathing conditions. So I'm actually getting up there and saying, this is wrong. You should not be restricting dentists. And I'm like, got your back, trying to make this happen. So this doesn't just stop with people having an opinion. This is what it escalates to. The American Academy of Sleep Medicine manages to recruit the American Medical Association to support their viewpoint and their contingencies that only physicians should be able to provide this diagnosis. So now the AMA and the AASM are saying the same thing. This is out of the bailiwick of dentists. And what they're actually doing is aggressive acts to get dentists into trouble if they do it. What do I mean by aggressive acts? They write letters to every dental board, every state dental board in the United States saying, we believe dentists should not be doing that. So 50 letters are sent out to the state boards, and they're trying to get the dental state boards to stop dentists and restrict dentists, and they're having some impact. Some of the states have actually said dentists can't do it. Other states have said, no, dentists can. But the vast majority of states are not making a comment one way or another. And that leaves dentists a little bit in the lurch. And one dentist, at least in California, has been attacked by the dental state board and questioned as to why was he doing diagnosis. He actually wasn't doing diagnosis, but they're questioning him, and now he's got to defend himself, and he's just the first. And so this has to be stopped before people in our field are damaged for doing something helpful to the patients. So the most recent position paper by the American Academy of Sleep Medicine has 6 conclusions. And you can see that these people that have written it, and there's quite a few people, but these are people on the board of directors. So this is the leadership of the American Academy of Sleep Medicine, and they have 6 conclusions as to what should be done. And I'm not going to give you all 6, but I'm going to give you 3 of them. The 6 are there, but down at the bottom, but look at the top. Number 1, only a medical provider can diagnose medical conditions such as OSA and primary snoring. Now, you know how they said primary snoring? Primary snoring is meant to be benign snoring. So now they're saying that not only can't dentists diagnose obstructive sleep apnea, but they can't even diagnose snoring. And the equivalency there is, I can't diagnose somebody with morbid obesity, or somebody even slightly overweight. And it's like, okay, this is just not realistic. There's more than 100 million people that have primary snoring, and now we're not even able to say, hey, you just have a simple case of snoring. And I guess the rationale is, well, you need to have a sleep test to be able to distinguish primary snoring from obstructive sleep apnea, and therefore, without you having the ability to do a sleep test, you're not able to distinguish. But actually, primary snoring can be distinguished other ways. And that is if somebody's snoring and they have no medical comorbidities and they have no other issues going on, it's like, okay, so they're just snoring. And you might say, well, they stop breathing a certain number of times. I go, yeah, but they have no medical comorbidities. Nothing's going on. You might go, well, in the future they do. And you go, all right, maybe if they're a world-class snorer. But if somebody's snoring once in a while, do we really think they need to have all this testing done, especially if it's this difficult to do? Excuse me, I need a little drink. Number 3 on the position statements, must be ordered by a medical provider. Home sleep apnea test. They're now saying, well, advanced care providers, you know, like nurse practitioners can do it too, but not dentists and not psychologists, even though psychologists were the ones that kind of discovered sleep disorders and they were the pioneers in sleep. They've been shut out too. And then they're saying, well, you know, you shouldn't even use these sleep apnea tests to screen people that are asymptomatic. And I go, well, since everybody snores at one time or another, nobody's asymptomatic. Number 2, people are testing themselves with their home apps and their iPhones and their Fitbits and stuff. So if they're doing it themselves, why is there a problem with us helping them do it? And then the other issue is, why not test people? If it's a simple test, why doesn't everybody get tested? People get tested with their blood pressure. They get tested for their cholesterol. Why shouldn't they get tested for problems with breathing during sleep? So you can see just those 3 out of the 6 positions make no sense whatsoever. But again, the AASM is the gorilla, and we have to figure out how to take on a gorilla without getting squished. So one of the things I look at and write about when I'm sort of advocating for dentists is there's a difference between competency and degree. Competency speaks to how well trained you are at something. How expert are you? Have you had training? Have you had credentialing? Do you have knowledge and experience? That deals with competency. Degree is I have an MD, I have an MPH, I have a DDS. Those are degrees. Just because you have a degree, just because you have a DDS, doesn't mean that you can do orthognathic surgery. Now, certainly some dentists with a DDS will do orthognathic surgery. Some dentists with a DDS will do general anesthesia on young children, but not every DDS does that. So there's a difference between the degree and the competency addresses the issue of specific training. So when we talk about medical conditions and we say, well, sleep-related breathing disorders, is that a medical condition? Is it a dental condition? I go, I don't care. It's a medical condition. It's a public health condition. I wouldn't argue that. I don't care. But you know what? Everything that we do in dentistry is also a medical condition. Sleep-related movement disorders are a medical condition. Well, what does that mean? Well, if you're going to kick your legs around during sleep or have restless legs in the evening, that's a medical condition. But guess what? If you have sleep bruxism or daytime bruxism, that's a movement disorder too. Is that a problem? Is that something that's a medical condition and we shouldn't be treating? And the answer, of course, is no. Dentists have been treating that since the beginning of dentistry. And then we could look at obesity and nicotine addiction, and we go, obviously, dentists should be dealing with this stuff. So here's one of the interesting issues with one of the states, and this is Georgia. And I'm picking on Georgia because it was so dramatic, the difference between their disapproval of dentists using sleep testing, so much so that they can't order a sleep test, they can't provide one, they can't do anything related to a sleep test. But yet we have no problem in Georgia with dentists doing behavior modification for smoking and nicotine addiction. In fact, we don't care if you are going to prescribe different medications, anti-anxiety medications. You can do whatever the hell you want to do to help somebody stop smoking. And you go, well, I don't get it. Why would you allow that? And people, you got to understand, every year, 450 to 500,000 people die from smoking every year. It's like, we don't have anywhere near that problem with sleep. At least we don't think so. And yet we don't have a problem with dentists treating smoking, which is much more deadly. And yet we have a terrible problem with them prescribing a test for sleep apnea. Again, it doesn't make a lot of sense. So now you can look at the original pie that's currently in existence from the AASM, and you can see the pie that I'm showing on the bottom right, and you can see how oral appliance has actually become 50% of the therapy for sleep-related breathing disorders. And I am being conservative. They are going to end up being more than 50%. And you might go, well, what's the other options? And you can look and see there's lots of other options, surgical options, preventive options, combination therapy, and other things. So there's a lot of things that are going to be a choice. Now, why do I think oral appliances are going to be a bigger part? Is because patients like them. When you compare people in studies, and there's been several studies where they've had the option to use CPAP, and then they had a washout period, and then they had the option to use oral appliance therapy. And they also had people that did it the other way around, oral appliance therapy first, and then a washout period, and then PAP therapy. Guess what? They were equivalent in impact. They both worked as well. Now, granted, positive airway pressure works better per hour of use, but oral appliances were used more hours. So it was a wash. And guess what else? When patients had to choose, they typically said, I want the oral appliance. In fact, more than 2 to 1 did they prefer the oral appliance. So picture this. Let's say 100 people were in the study. Over 50 of them said, I prefer oral appliance. 25 said, I prefer PAP. And the other 25 said, I don't want either, or I can use either. So you can see that oral appliance therapy is definitely going to be used about twice as much as PAP, and probably more as time goes on. So you got to look at where we are now in dentistry and what can we do. And I got to say, some of the people on the board of the American Academy of Dental Sleep Medicine are, sticking their necks out a little bit, and people are kind of timidly saying stuff that maybe dentists should be doing it. But no one is really standing up and saying, you know what, dentists need to diagnose it. Dentists are smart enough to diagnose it. Dentists can do this stuff. I'm doing that. I'm actually standing up, maybe because I'm towards the end of my career, maybe because I just don't care anymore, maybe because I've got that much education that I feel a little bit isolated or insulated against attack. But you never know. Somebody could attack me. But the bottom line is, let's not say nothing, and let's not pretend it's not a problem, and let's not just shut our ears to the issue that's going on. And now that I've told you, I want you to think about advocating for dentists to do it. So I mentioned Healthy Sleep 2020. Well, this is Healthy Sleep 2030, and it changed only a little bit. How did it change? Well, there were a few more goals that were listed, but the overall goal is a kind of noble goal: improve health, productivity, well-being, quality of life, and safety by helping people get enough sleep. That sounds good to me. I like that. And they had some different criteria on why this was important. 1 in 3 adults and even more adolescents don't get enough sleep. People that have a lack of sleep are more likely to have other health problems related to it. Like if you have sleep apnea, it tends to lead to hypertension. It's actually a cause-effect relationship. And sleep disorders can affect all sorts of other things in people's lives, including safety issues. And so it does make sense for us to push for people to get better sleep. And here are the kind of the new sleep health initiatives. And you can see that some of them are just broken down. Like the first one, motor vehicle crashes, we spoke about that. More adults with better sleep, increase the proportion of adults that get tested for sleep apnea, increase high school students. This is kind of like the pre-existing ones. They just changed 3 to 4 initiatives. And then they said, okay, let's not just limit it to adults and to adolescents. Let's also make sure younger children get enough sleep. And younger children may need 10 or 12 hours of sleep a night. And let's make sure that the infants that get sleep are put to sleep on their back, because infants that don't sleep on their back have a higher proportion of SIDS, sudden infant death syndrome. And make sure infants are in a safe environment, meaning that some infants could be in a bed with an adult who rolls over the infant and squishes them, suffocates them. So let's make sure people understand about that. And of course, let's increase the proportion of secondary schools with a later start time, which we've already done in California, and thumbs up that California was ahead of the game on that one. So what is advocacy? It's a political process by an individual or a group, and we want to influence decisions. We want to make a difference. We want to actually have dentists be some of the primary care sleep providers. And this takes more and more dentists interested in doing it, and doing it the right way. I mean, don't be cavalier. Don't take a weekend course and then pretend that you know it all. I mean, take the journey, do it well, and then teach somebody else. And why this is a brave new world is we're trying to do things differently. And the reason we have to do things differently is that whatever the parameters and the paradigms of treatment, they're changing. Just think of artificial intelligence and how that's changing how we're treating people, and personalized medicine. And think of it this way. It used to be that only a sleep physician could read a sleep test and interpret it. Well, guess what? The auto scoring devices using artificial intelligence are going to be much better than sleep physicians, and they're going to be more accurate, and they're going to look at more data than just the apnea and hypopnea index. And just so you know, an apnea is when somebody comes close to stopping breathing. It's like 90% reduced breathing. Like if I were to have an apneic event, it will be like this. And then after a few seconds, 10 seconds or more is the limit, it will be this. That's an apneic event. Whereas a hypopneic event is when I have labored breathing, like that kind of a thing. And because I'm doing that, my oxygen level drops and I have a cortical arousal, and those sort of things are scored as hypopneas. So with an apnea hypopnea index, they're scoring how many times somebody stops breathing for 10 seconds or more, how many times they have that labored breathing with a desaturation, and they add them up throughout the whole night, because they're often worse in certain sleep stages like REM sleep. When you're paralyzed, you probably have more sleep apneic events and hypopneic events. Well, you average them out through the whole night, and if it's more than 5, you're considered to have sleep apnea. Well, guess what? The apnea hypopnea index is not a good marker. So we're using a scoring and a marker that doesn't reflect actual health. And this happened just recently, March 2021. And when I read this report, I was emailing people all around the world, my colleagues that I work with and stuff, saying, can you believe this? There is now insufficient evidence that AHI can work as a surrogate or a testing kind of marker. Can you believe that CPAP doesn't really affect long-term health outcomes? And that if this AHRQ report, which is what gets sent to government like CMS, which is Medicare, when they get this information, they may stop funding for patients to have CPAP because it's just not enough evidence that it works, whether it keeps them alive. And you go, wow, that is really scary. And there's even less evidence for oral appliance therapy. So we have to rethink using the apnea hypopnea index, maybe using the oxygen desaturation index, or maybe using the cardiopulmonary kind of measures that we can get through plasmography, or maybe we're going to look at other things, but we're certainly not going to just rely on the AHI, and we're not going to just rely on CPAP. So the world is changing, and this report had a 30-day response time, and all the sleep societies responded. They all joined together and said, this is horrible, don't do this, CPAP helps. We need to be able to give patients CPAP, and certainly it does help, but it's like there aren't enough randomized clinical trials to validate it. And remember, you can't necessarily put somebody in a randomized clinical trial if you think that they're going to die from non-treatment. Anyway, these are your next steps, how to play it safe, and what you should do. You want to call us, you can get, or just email us, get the poster, get the book, put them in your practice, start having patients open up the conversation about sleep and what you can do to help. Teach people about sleep hygiene, teach them, okay, these things can help, because if somebody sleeps better, their immune system's better, they live longer. There's a lot of reasons for people to get good sleep, and that little poster and book can be helpful to you. Education, how do you know that you're getting good education in sleep? Well, you want to make sure you go to somebody that's really credentialed. I mean, have they published? Are they just, like I've seen so many lectures where it's the Invisalign lecturer that's decided they're now the expert in sleep, and they talk about that, or somebody else who really has no authentic credentials, doesn't have any special training. They're just self-professed sleep experts, and there're just so many of them, more and more. I mean, I go to lectures and I listen to people and what they say, and I go, that's not right, that's not correct. And I'm thinking, the people that are listening to the lecture don't know that they've been given bad advice. So make sure you go to good programs. There's a lot of university programs at USC. There's a 2-year master's in orofacial pain and sleep medicine. There's others at different schools. Tufts has a program, and there's like also education through the American Academy of Dental Sleep Medicine. But just remember, this is a big topic, and it's a journey to get good at it. I mean, I didn't arrive where I am over a month or a year. I've been doing this for 20 or more years. And when I say doing it, I mean, I am reading. I am hour, 2 hours, 4 hours, 8 hours, writing publications, researching stuff. I've published research that shows that dentists actually need about 100 hours of formal education to feel competent in managing sleep apnea and stuff like that. So think about 100 hours as being something that sort of a step for you to do. So I'm here to answer questions. I apologize if I went too fast or too long, but I hope I got you irritated enough that you'll do something. And just one of the things that is so recent that I've written another couple of articles. One article that shows after the research I did that dentists know as much about sleep apnea as physicians, and I show it in proof, and I do lots of evidence to validate at least California dentists, and that'll be published hopefully in because I'm doing minor changes from the journal. And the other thing I wrote is another kind of testimonial report about how people have said from the leadership of ASM how dentists are encroaching on their territory and how they have to protect the field of sleep medicine from dentists. And nothing could be further from the truth, because the more dentists you get involved, the more sleep problems we're going to catch, the more serious sleep problems we're going to get to the experts, and it's going to help the United States if more dentists are engaged. And just think about it with high blood pressure. If only cardiologists were looking after people with high blood pressure, you'd have such a line that the people with very serious cardiomyopathies wouldn't be managed and they'd be dying. So we need to have step care. We need dentists. We need people like you to get engaged, and we need you to fight for other dentists to do it and not, you know, accept this faulty kind of approach that this is a medical problem that dentists can't manage or be involved in helping it. Thank you so much for listening.
Michael, if you could unshare would be nice. You can join everybody on the screen, and when you're ready, let me get myself too. All right, Michael, amazing. Thank you very much. Amazing presentation, so engaging. I want you to know, love the passion you have in this subject, especially. Thanks for standing up for us, advocating for us is amazing. And I knew little, but the degree you presented tonight was impressive how far you have gone. I want to thank you for the late start time, which is going to come soon, for our children. And I'm sure many may have questions, so I'm going to open the floor for questions. Please feel comfortable to join, unmute yourself if you have any questions for Michael. You see how thorough you were?
I hope I didn't put anybody to sleep, but in the same light, I'm glad they're sleeping.
No, that's funny. I had a question about California. So in California, dentists aren't allowed, or they're supposed to work with a physician, or how does it work here?
So California's been silent on whether dentists can prescribe or give patients a sleep test. And I got to tell you that in other states recently, like in New York, the dental state board just one day decided that dentists couldn't use sleep testing. And the dentist experts in sleep, and there's a bunch in New York, were like shocked, like, how could this happen? And the answer is, people were advocating against dentists doing this, and they managed to convince the state board to make this judgment call. And they have some liberality in deciding because they work for the public. So state boards is kind of like Department of Consumer Affairs protection of dentists, protection of patients. And that may mean, oh, we need to protect the patient from having to spend money on bleaching with a dentist. Let's allow them to do home bleaching, or let's protect the public from medications that aren't well proven. So what happened is they managed to convince the state board of dental examiners that it was dangerous for dentists in New York to prescribe or give patients a sleep test. And so in California, I can promise you the California Board of Dental Examiners knows about me and knows that if they start this, that they are going to have somebody that's going to be barking up their tree and going, this is wrong, you can't do this. And they know that at least one person will push back in a big way. But it takes more than just one dentist. You know, even if that one dentist has a lot of passion, it takes patients that say, you know what, that dentist helped me. Whereas the physician and the CPAP were not effective, I was untreated, they managed to help me. So you need patient advocates, you need dentist advocates, and you need to push it. So right now, think of California as being a fence sitter. We have one doctor I know of that's being attacked by the dental state board. I can't tell you the details, but just understand that I'm involved in it. And there's also other dentists that there's been some question about, and it will come down to who has the better argument, who has the better advocacy. So if you have, and this is sad to see, but if you have the American Academy of Sleep Medicine repeatedly recruiting other physicians against dentists, it makes it very hard for the state board. So for instance, I had told you back in 2017 that the American Academy of Sleep Medicine had got the American Medical Association to write a letter with them to every state board in the United States to say dentists should not be doing sleep testing. Well, guess what? In the last few months, the American Academy of Sleep Medicine got the American Academy of Otolaryngology, the American Academy of Thoracic Surgeons, and the American Academy of Neurology to write a letter to every single state board in the United States saying it's wrong for dentists to be using sleep testing devices, and they shouldn't be diagnosing sleep apnea because it's a medical condition. So can you see how they're working on advocacy? They're pushing the envelope and they're trying to restrict dentists. And in New York, they blindsided them. In California, I will do my best to not be blindsided. And I've been in front of the Board of Dental Examiners once or twice to try to describe the issues. And I've also written them and said, please let me come and talk to you. And they're basically saying, oh, you know what, we'll let you know when we want to hear from you. And I am just a nuisance because I will not let them get away with it. And it's the same thing with CDA. With CDA, when I get up to speak, people are like groaning, oh no, not another sleep issue. And it's like, yeah, it's another sleep issue. Until we get it right, I'm going to keep advocating for the dentists. And unfortunately, some dentists at CDA don't believe that dentists should be doing it. And a lot of times it's oral surgeons. And I'm going, why are you preventing dentists from doing it? And perhaps they think that dentists aren't knowledgeable enough or qualified enough. Well, guess what? The research shows that physicians get 3 hours of education in all of sleep issues in their 4 years of medical school. 3 hours. And I did the research on dentists and published it. And guess what? For dentists, it's 3 hours. In New Zealand and Australia, I also published on that. It was 4 hours. So I'm just saying that it's increasing in dental schools, but I don't know if it's increasing in medical schools. My youngest son started medical school, and he's tracking for me how much education he's getting in sleep through his whole career at school. So I'm going to know, from an insider's viewpoint as well. But in answer to your question, it's a fence-sitting issue. If you feel like you could defend yourself doing it, do it. Would I defend you doing it? Yes. So hopefully that's enough, but only if you've got enough education and background to believe that it's okay for you to do it and you know how to do it. And you got to follow the community standards. Like, what do physicians do? How are they doing it? How are they getting it interpreted? It must be interpreted by a sleep physician, whatever sleep testing you do. Eventually, forget the sleep physicians, it's going to be artificial intelligence. And it's not going to be long, because these newer plethysmography type testing devices, they don't use the same criteria. They use different data points. It's very exciting to see these changes.
Michael, I know one of our colleagues was asking, in the situation where there's a requirement for a physician to be involved, and the dentist wants to, actually, you're more and more you're aware of the airway issues and sleep apnea. What should they do when they see a patient in their practice?
So sleep disorders, sleep apnea, any sleep disorders, it's a team sport. Team, you cannot do it alone. So if you're going to be a cowboy and just do it by yourself, that's going to put you into serious trouble. However, I don't mind you taking the lead. I wouldn't have a problem with that as long as you're working with a physician. So you would speak to the primary care doc or give them a note saying this is what you did. Let them know these are the results. These were the interpretations. This is what you would recommend doing. This is what the patient wants to do. See if they get back to you. A lot of times physicians don't. I've had, through my years of dealing with physicians, I've had some that have been really nasty, but I've also found that most of them are really caring, really care about the patient, want to do the best thing for the patient. So even though I've had some where I go, wow, that's a great story, I should write that one up because people will be amazed at the message that physician gave. That's not the general rule. The general rule is they want to help the patient. They're kind of busy. They don't really want to do sleep. They don't know a lot about sleep. They have to know a little bit about. Oftentimes they will take their lead from you, providing you're using a medical model, which means you have to use a proper history and physical. You have to write up a report. You have to keep SOAP notes. You got to do the medical model. so that you are able to communicate with them, and you've got to stay in communication with them. So if you do it with other people, do it with a physician, do it with a sleep physician, do it with the otolaryngologist. I mean, I work with so many otolaryngologists, I can't even tell you. I mean, I'm literally getting a referral a day from otolaryngologists. All right. So, I mean, these guys, they want to have some help. They're very good at their part, but they don't want to do a lot of the little things. They want other people helping so that it's not all on their shoulders.
Anyone?
Yeah, the next question is, so based on the outcome of the test is when you decide what is the right path, correct? So if like the test comes back a certain way, then you cannot make a appliance, you have to do a CPAP. Is that correct? Based
No,
on
no, that's the, think of that as the old school. The old school was you should give everybody CPAP. The reason for that is oral appliance therapy was not validated so much. And also there's a group of people where oral appliance therapy doesn't work. It's not 100% successful. CPAP is not 100% successful either, but it might be more than 90% successful, whereas oral appliances may be only 80% successful. So you might go, okay, it's a more reliable thing. And then you got to understand that CPAP is like off the shelf. It doesn't matter if I prescribe it or 100 of my colleagues prescribe it. They're getting the same machine, and they maybe just get a different interface mask. But an oral appliance, there's lots of different ones, lots of different skill levels of the dentist. And a lot of times people have other problems like jaw problems or issues adapting to the mouthpiece. So you may find that physicians are not that comfortable because, number one, they've lost control of the patient. Number two, they don't think it's as effective. And so they really want to push their agenda, and they're taught. So you got to understand that the few hours that the regular physicians are taught is that you need to give the patient CPAP. They've been kind of like preconditioned to think that that's the only answer. The reality is, if patients understand all the options, like I have a lot of patients that use CPAP. You know, I say to them, you need to use CPAP. I won't monitor the CPAP because you have to look at it every day, how compliant they are and stuff like that. So it doesn't make sense for me to do that. That's not my area of expertise, but I oftentimes will make somebody an oral appliance that fits and holds their CPAP interface. Or I have people use combination therapy. So when you get a diagnosis of, let's say, sleep apnea, or maybe a diagnosis of primary snoring, then you've got to decide, okay, what do I do? Well, if it's primary snoring, theoretically not sleep apnea, you should theoretically be able to do the treatment without any physician like collaboration or oversight. But if they have sleep apnea, you theoretically, you don't absolutely, but you theoretically need a prescription from the patient's physician. And you may go, well, why would I need that? And the answer is because otherwise the insurance won't pay. And will they pay in most cases? Well, they'll pay if it meets the criteria. The criteria may be they have to have some systemic comorbidities with some sleep apnea, meaning their sleep apnea is not moderate or severe, but they have daytime sleepiness, or they have hypertension, or they have depression, mood disorders. They have something so that the medical insurance says, okay, I'm going to check off that box. I think we're going to pay, but oh, you don't have a prescription for a physician, we're not going to pay. So in other words, insurances have their own routine. Like, we will only pay if you fulfill all these criteria. And one of the criteria is if somebody has sleep apnea, they have to have a prescription from a physician who has seen the patient, had a face-to-face kind of exam, before they will give that, pay that prescription for oral appliance therapy. And the dentist, if they're trying to help the patient get reimbursed, will jump all the hoops and cross all the T's to try to help the patient get reimbursed. But reimbursement, medical billing, and all that sort of stuff, it's not an easy thing. I mean, I've been doing it for years, and I can tell you it's not an easy thing. So, and I would caution you all, if you think, oh, this is an easy income stream. No, it's not an easy income stream. Buccal pit fillings, that's an easy income stream. Okay. It is not easy to be fitting people with oral appliances and helping them adjust and do all that sort of thing. So I would be very careful about people that are trying to convince you to jump on the bandwagon and buy all this equipment. And unless you have a real passion for it and you don't care about taking a loss and you're doing it just because you love the subject, I would be much more careful about jumping into this like you're going to earn a lot of money, because I don't think it's going to happen, not unless you really get lucky and you have a really good skill set.
Michael, amazing. Thanks for sharing your passion. I think we have enjoyed you for a good 2 hours now.
Oh,
so
geez, I'm sorry.
I'm looking forward for future time for you to come back. And again, thanks for being such a great friend. Guys, thanks for not falling asleep. I know the subject was very engaging. You didn't see there were so many chat going on saying thank you, Michael. Thank you, Dr.
Good.
Simmons, for tonight. Everybody, look forward at seeing you guys all next time. Enjoy dentistry, enjoy life, and be safe. Thanks.
Bye.
Bye.